It's a great pleasure and honor to join you today and share our Tunisian experience in the management of pediatric Philadelphia acute lymphoblastic leukemia. Before I begin, I would like to apologize for presenting in French. It's easier for me to express. Thank you for your understanding. Comme vous le savez, les leucémies aiguës lymphoblastiques avec chromosome Philadelphie sont rares chez l'enfant. Elles représentent 3 à 15% des leucémies aiguës lymphoblastiques. Sa fréquence augmente avec l'âge pour atteindre 40% chez les patients adultes âgés de 55 ans et plus. Les premiers à avoir introduit l'imatinib chez l'enfant, ce sont les Américains, le Children's Oncology Group. Ils ont mené une étude prospective randomisée comparant 5 cohortes, donc avec une augmentation progressive de l'imprégnation par l'imatinib. Dans la première cohorte, l'imatinib a été donné au cours de l'intensification numéro 1 et l'intensification numéro 2. Et dans la cohorte 5, l'imatinib a été donné en post-induction d'une façon continue. Les résultats préliminaires de cette étude ont été publiés dans JCO en 2009. Ils étaient remarquables, avec une survie sans événement à 3 ans de l'ordre de 80% versus 35% pour une série historique. Cette étude a été poursuivie et les résultats définitifs ont été publiés dans Leukemia 2014. Donc, ils ont montré que la survie sans événement pour la cohorte 5 qui ont reçu l'imatinib avec chimiothérapie était de 70% versus 65% pour des patients ayant reçu une greffe géno-identique versus 59% pour les patients traités ayant reçu une greffe non apparentée. L'objectif de notre étude est d'évaluer les résultats thérapeutiques des leucémies aiguës lymphoblastiques, évaluer l'impact de la réponse moléculaire précoce sur la survie et le risque de rechute, analyser l'effet de la durée d'exposition aux inhibiteurs de tyrosine kinase et comparer les résultats de l'allogreffe en première émission complète versus chimiothérapie associée aux ITK. C'est une étude monocentrique réalisée au service d'hématologie clinique de l'hôpital Aziza Othmane entre janvier 2006 et décembre 2022. 531 leucémies aiguës lymphoblastiques de l'enfant ont été diagnostiquées et traitées. 32 sont des LAL Phi+, soit 6%. Tous les patients ont été traités selon le protocole AORTC 58-951 bras au risque, avec l'introduction de l'imatinib dès la réception du résultat de la cytogénétique et ou de l'étude moléculaire. Tous les patients ont reçu une induction à 6 drogues avec dexaméthasone, vincristine, daunorubicine, asparaginase. En plus, ils ont reçu du méthotrexate haute dose à 5 grammes mètre carré et de l'endoxan 1 gramme mètre carré à J9. Donc, tous les patients ont été traités selon le protocole ERTC bras au risque. Les patients qui avaient un donneur géno-identique ont été proposés pour une greffe en première émission complète en sachant qu'en Tunisie, il y a un seul centre de greffe et seules les greffes géno-identiques sont réalisées. Les patients qui n'avaient pas de donneur géno-identique donc, ont poursuivi leur traitement avec la chimiothérapie et imatinib, à savoir que l'imatinib n'a pas été arrêté à la fin du traitement d'entretien, il a été poursuivi, et ça pour une durée qui dépend du prescripteur, du médecin. Donc, les médecins avaient peur d'arrêter l'imatinib parce qu'ils n'avaient pas beaucoup d'alternatives thérapeutiques en cas de rechute. En deux patients, 72% sont de sexe masculin, l'âge médian est de 11 ans, le taux médian des globules blancs est de 130 gigas par litre, 59% des patients avaient un taux de globules blancs supérieur à 100 000, 3 avaient une atteinte du système nerveux central, 50% des patients avaient des anomalies cytogénétiques associées et tous les patients avaient le transcrit P190. Les patients étaient stratifiés en groupes de risque selon l'étude de la corticosensibilité à J8, l'étude de la chimiosensibilité à J19 et de l'étude de la rémission complète à J35. Étaient classés faible risque ou risque standard les patients corticosensibles, chimiosensibles à J19 définis par un taux de blast inférieur à 25% et qui étaient en rémission complète en fin d'induction avec un transcrit inférieur à 1%. Les patients qui étaient corticorésistants et ou chimiorésistants en échec ou qui gardaient un transcrit supérieur à 1% en fin d'induction étaient classés au risque. L'imatinib a été introduit dès l'induction avec un délai médian de 9 jours, des extrêmes allant de 3 à 23 jours. 77,5% des patients ont reçu l'imatinib avant J15. 42% étaient corticorésistants. 10,3% étaient chimiorésistants, un décès par le costase, 2 décès par choc septique, soit 6% en induction, et 90,6% des patients étaient en rémission complète. 28% des patients ont gardé un transcrit supérieur à 1% à J35 de l'induction. La stratification des patients en groupe de risque a montré que 48,3% des patients étaient classés au risque. Donc, 32 patients, 3 sont décédés au cours de l'induction, dont 2, soit 6% par choc septique. 29 patients étaient en rémission complète. 8 ont été greffés en première rémission complète, soit 27,5%. Et 21 patients ont été traités par chimiothérapie et imatinib. Si on regarde les patients qui étaient greffés en première rémission complète, en nombre de 8, 6 ont bénéficié d'une greffe géno-identique, dont 2 sont décédés en post-greffe. 2 patients ont bénéficié d'une greffe de cordon, dont 1 est décédé en post-greffe. Donc, si on récapitule pour les patients greffés en première rémission complète, on n'a pas noté de rechute en post-greffe. Cependant, 37,5% des patients sont décédés par toxicité liée à la greffe. Pour les patients traités par chimiothérapie, qui sont au nombre de 21, 11 patients ont rechuté. 2 ont bénéficié d'une greffe de cordon. Malheureusement, tous les 2 ont rechuté en post-greffe et sont décédés. Donc, pour les patients traités par chimiothérapie et imatinib, on n'a pas eu de décès toxique, mais 52% des patients ont rechuté. Pour les patients qui ont eu chimiothérapie et ITK, donc comme ça a été déjà dit, l'imatinib n'a pas été arrêté après la fin du traitement d'entretien. Il a été poursuivi avec un délai médian de 52 mois et 10 patients ont reçu l'imatinib pour une durée de plus de 5 ans. Si on raisonne en groupe de risque, 15 patients étaient classés faible risque ou risque standard, 4 ont bénéficié d'une greffe en première rémission complète, 3 sont vivants en première rémission complète. 11 patients ont été traités par chimiothérapie et ITK, il y a eu 4 rechutes. Donc, pour les patients risque standard, 67% des patients sont vivants en première rémission complète, 27% de rechutes et 7% de décès toxiques. Pour les patients classés au risque, au nombre de 14, seulement 4 ont été greffés en première rémission complète, soit 28,5%, dont 2 sont décédés. Et les patients traités par chimiothérapie imatinib, 7 ont rechuté. Donc, au total, parmi les patients qui sont classés au risque, seulement 36% des patients sont vivants en première rémission complète, 50% de rechute et 14% de décès toxiques. Avec un suivi médian de 92 mois, la survie globale à 5 ans était de 57,9%, la survie sans événement est de 47,5% et la survie sans rechute est de 58,5%. Nous n'avons pas noté de différence significative en termes de survie en fonction des facteurs pronostiques pré-thérapeutiques. Cependant, on note un avantage de survie pour les patients qui avaient un taux de globules blancs inférieur à 100 gigas, survie globale à 84,6% versus 40% pour les patients qui avaient un taux de globules blancs supérieur à 100 000, mais la différence est non significative. L'étude des survies en fonction de la clairance blastique, on note un avantage de survie pour les patients qui étaient corticosensibles, chimiosensibles, mais la différence est non significative. Et les survies étaient significativement meilleures pour les patients qui avaient un transcrit inférieur à 1% à J35 de l'induction. Survie sans rechute pour des patients ayant un transcrit inférieur à 1% était de 66,2% à 5 ans versus 20% si le transcrit est supérieur à 1%. L'analyse des survies en fonction de la réalisation, oui ou non, d'une greffe en première rémission complète. Donc, pour la survie globale, pour les patients qui étaient greffés en première rémission complète, la survie globale était de 62%, avec un plateau qui a été obtenu précocement dès le 24e mois. Par contre, pour les patients traités par chimiothérapie et ITK, pas de plateau, avec une survie globale à 5 ans qui était de 64,5%. Et quand on regarde les survies en fonction des groupes de traitement et en fonction des groupes de risque, pour les patients qui étaient classés risque standard, la survie sans événement pour les patients greffés en RC1 était de 75%, en sachant que le principal événement, c'était le décès toxique, alors que pour les patients traités par chimiothérapie et imatinib, la survie sans événement à 3 ans était de 90% et elle passe à 64,9% à 5 ans. Donc, des rechutes, le principal événement, c'est des rechutes, et les 3/4 des rechutes sont survenues au-delà de 36 mois. Pour les patients qui sont classés au risque, la survie sans événement pour les patients greffés en RC1 est de 50%, avec un plateau qui a été obtenu à partir du 12e mois. Et pour les patients au risque traités par chimiothérapie ITK, le principal événement, c'est des rechutes, mais cette fois-ci, ce sont des rechutes précoces, early relapse, avec une survie sans événement à 36 mois de 40%, elle passe à 30% à 5 ans. L'étude de la survie en fonction de l'exposition et de la durée d'exposition aux inhibiteurs de tyrosine kinase. Dans cette étude, la survie sans événement était significativement meilleure pour les patients qui ont reçu l'imatinib pour une durée de plus de 5 ans, 70% versus 22,7% si l'imatinib a été reçu pour une période de moins de 5 ans. Et en analyse multivariée, les paramètres qui gardent une valeur pronostique, c'est essentiellement l'étude du transcrit à J35 et la durée d'exposition aux inhibiteurs de tyrosine kinase. Dans notre étude, tous les patients ont reçu une induction à 6 drogues avec un décès au cours de l'induction de l'ordre de 6%. Les différents protocoles pédiatriques Donc, préconise plutôt une induction à 3, voire 4 drogues au maximum. Si on regarde un peu les études, là, c'est une étude française, le graphe 2005. C'est une étude randomisée où ils ont comparé deux bras pour l'induction. Le bras A, donc c'est une induction qui est basée essentiellement sur la vincristine, la dexaméthasone avec l'imatinib. Et le bras B, c'est une induction type hypersévate. Ils ont démontré dans cette étude que le taux de rémission complète était significativement meilleur dans le bras mais vincristine d'hexaméthasone, 98,5% versus 91% pour le bras hypersévate. Ceci est expliqué par un taux de décès en induction qui était plus élevé dans le bras hypersévate. Et malgré une induction qui soit moins intensive avec le bras vincristine d'hexaméthasone, ceci n'a pas impacté la survie sans événement. Là, c'est une étude canadienne qui vient d'être publiée dans Current Oncology en 2026. Ce sont des adultes qui ont été traités par un protocole d'inspiration pédiatrique. De 2001 à 2009, tous les patients ont été traités par ce protocole d'inspiration pédiatrique. 70% ont reçu de la L-asparaginase et 44% ont été greffés en RC1. De 2010 à 2015, vu la toxicité liée à la LASPA, ils ont décidé d'arrêter de ne plus donner de LASPA. Donc, de 2010 à 2015, ils n'ont pas donné de L-asparaginase, mais 39,6% des patients ont été greffés en RC1. Et à partir de 2016, ils ont décidé de réduire les indications de greffe en première rémission complète. Donc, de 2016 à 2019, pas de LASPA et seulement 25% des patients ont été greffés en première rémission complète. Dans cette étude, la meilleure survie globale était pour les patients traités de 2016 à 2019 sans LASPA et en diminuant les indications de greffe en première rémission complète. Donc, en Tunisie, nous sommes en train de réfléchir pour un nouveau protocole et dans l'avenir, ça va être une induction à 3-4 drogues pour nos patients, plus d'induction à 6 drogues et on va réfléchir si on va donner de la L-asparaginase et éventuellement diminuer les doses d'anthracycline. En Tunisie, il y a un seul centre de greffe et seules les greffes géno-identiques étaient réalisées à cette époque. Dans notre étude pour le bras au risque, seulement 28% des patients ont été greffés en première rémission complète, avec 37,5% de mortalité liée à la greffe. Donc, on doit réfléchir sur d'autres alternatives thérapeutiques et éventuellement diminuer les indications de greffe en première rémission complète. Pour les patients traités par chimiothérapie et ITK, on n'a pas eu de décès en rémission complète. Cependant, 52% de rechute et tous les patients qui ont rechuté sont décédés. Et quand on regarde par groupe de risque, pour les patients classés risque standard, il y a eu 36% de rechutes et les 3/4 des rechutes, ce sont des rechutes tardives. Par contre, pour le bras au risque, traité par chimiothérapie et ITK, 70% de rechutes et ce sont des rechutes plutôt précoces. Donc, on doit réfléchir pour les patients qui sont classés risque standard, comment doit-on faire pour prévenir ces rechutes tardives? Et pour les patients qui sont au risque, il y a quand même 70% de rechutes pour les patients traités chimio-ITK. Le pronostic reste défavorable et on doit réfléchir à d'autres alternatives thérapeutiques. Donc, risque standard, rechute tardive. Le groupe européen ESFAL et le Children Oncology Group recommandent de ne pas faire de greffe en première rémission complète. Pour les hauts risques, ce sont essentiellement des rechutes précoces avec un pronostic qui reste défavorable. Nous avons montré dans notre étude que les survies étaient significativement meilleures pour les patients qui avaient un transcrit inférieur à 1% en post-induction. Les différents groupes coopératifs préconisent de réaliser un deuxième point pour mieux stratifier les patients en groupe de risque et nous allons donc préconiser pour nos patients la réalisation d'un deuxième point pour l'étude de la maladie résiduelle en post-consolidation et seront classés risque standard les patients qui ont un transcrit inférieur à 1% en post-induction et inférieur à 0,01% après consolidation. Dans cette étude, nous avons également démontré que 70% des patients qui ont reçu de l'ITK pour une durée de plus de 5 ans avaient une survie sans événement qui était significativement meilleure, de l'ordre de 70%, versus 22,7% si la durée d'exposition était inférieure à 5%. Il n'y a pas eu d'études qui ont publié des résultats similaires. Qu'en est-il des ITK deuxième génération? La seule étude randomisée qui a comparé le dasatinib par rapport à l'imatinib est une étude chinoise publiée dans JAMA 2020. Dans cette étude, seulement 2% des patients ont été greffés en première émission complète et les différentes survies étaient significativement meilleures dans le bras dasatinib, avec une incidence cumulée de rechute plus élevée dans le bras imatinib, sans pour autant qu'il y ait plus de toxicité. Les adultes sont en avance par rapport au protocole pédiatrique. Ils ont introduit des ITK troisième génération à partir de 2018. Et la révolution, c'est avec l'introduction de l'immunothérapie, le blinatumomab, à partir de 2020. Les Italiens, donc, constitue un modèle pour la prise en charge des LAFI+ de l'adulte. Et là, vous voyez l'amélioration du pronostic au cours des années.
At this time, please. If we can conclude, please.
OK.
Yes, thank
In
you.
the future, nous allons réfléchir pour un nouveau protocole avec une induction à 3 à 4 drogues seulement, éventuellement une randomisation ELASPA ou pas de ELASPA. Pour les patients qui sont classés risque standard, pas de greffe en première rémission complète. Et afin de prévenir les rechutes tardives, nous pensons à alterner 2 cycles de blinatumomab, bien sûr en association avec l'imatinib pour une durée de 5 ans. Pour les patients qui sont classés haut risque, donc on préconise plutôt le dasatinib à 80 mg/m². Les patients qui auront un donneur géno-identique seront proposés pour une greffe en première émission complète. Sinon, le traitement sera poursuivi par chimiothérapie et dasatinib. Thank you for your attention.
Thank you, Dr. Yosni Abedemi. Your slides were very good. I could pick out a few things.
Okay. We had trouble also with our share of screen with Dr. Abdan Bish. It was blocking anytime someone get in the webinar. I hope that things go better with my presentation. Can you see my screen?
Absolutely, yeah. It's quite clear.
So my presentation is about genetic and molecular biomarkers of pediatric BELL, a foundation for standardized national protocol. Oh, this is not... Okay. Start again. So the webinar plan is to speak about the incidence of pediatric leukemia worldwide, and I will highlight the incidence in Tunisia, the genetic and molecular stratification, a quick review of the genetic and molecular stratification of ELL, pediatric ELL, and then our approach as a genetic and molecular approach in our laboratory for the diagnosis of pediatric acute lymphoblastic leukemia. And then I will try to present our reflection, how to advance our protocol with a practical phased protocol to implement and standardize. So just very quickly, pediatric leukemia is the first and the most frequent childhood cancer and leading cause of pediatric cancer mortality. About 77,000 new pediatric leukemia cases in 2022 and 31,000 deaths from pediatric leukemia in 2022 from Globocan. ELL is presenting about 67% of all hematological malignancies, pediatric leukemia, with the BLL being the most frequent immunophenotype. In Tunisia, we have in 4 regions, 7 university centers taking in charge pediatric patients with acute leukemia. So they are the reference center. In Tunis, we have 3 hospital university centers and 1 in Sousse, Monastir, and Sfax. And our registry data is limited, so we are trying to get incidence in Tunisia from our hospital-based series, and we are about 66 average of new cases per year, which is corresponding to 2.3 by 100,000 population. And this is not far from what is reported for worldwide incidence of pediatric acute lymphoblastic leukemia. But I would like to highlight that this is not complete or comprehensive data, as we don't have any regard or view on patient treated in the private sector or abroad. So this is our incidence taken only from university hospital data.
Recording in progress.
So for the survival, the 5-year survival rate for childhood cancer, pediatric leukemia, is well improved, about 90% in high-income country. But unfortunately, in low and middle-income countries, the survival rate reported as low as 40%. And I would like to highlight that 80% of children and adolescents who are diagnosed with cancer live in these low and middle-income countries. So I think there is attention should be given, especially to these countries where children with leukemia are mostly living. Our survival rate, global survival rate for pediatric patient ELL in Tunisia are from between 60 and 70% from our preliminary data. So I wanted to just remind you how genetic abnormalities or alteration are dictating the therapeutic decisions now. More and more we see in the protocol, and here is all together, which is European protocol and ongoing protocol. And we can see here all the paths that patients are sent in depend on also the stratification of patient and standard risk, intermediate risk, and high risk. And let me remind you that standard risk or any risk of leukemia, this basically defined also on how are the genetics or the somatic genetics of the leukemia. So, for example, if we see standard risk patient, we need to eliminate any high-risk genetics associated to the leukemia. Also, for the classification 2022 WHO classification of BLL, there is an interesting change. So we see with any new classification, WHO classification, that we are genetic entities are increasing with ELL. So in 2022, there were at least 3 new entity, which is phi-like leukemia. Phi-like leukemia was a provisional entity in 2016 WHO classification. Now it's well-established class of BLL. ETV6 ranks 1 like, also it's a new entity, TCF3 HLF. And also I wanted to remind that B others are also an entity with very heterogeneous genetic alteration, as is the case for Phi-like ELL. So the idea is we have new entities, but these new entities are also a group of different genetic and variation, including SNV, copy number variation, and fusion genes. And this is what complicates now how our practice should be advanced to be able and capable to detect and reveal all these heterogeneous alteration, including and thinking about more and more implementation of pangenomic techniques. So we tried in 2023 from our practice in Tunis, between our two labs in Institute Pasteur of Tunis, the genetic lab and the molecular hematology molecular lab, to see what is our current approach and to compare what we are detecting with the cohort as reported in the literature. So we can see that we are using basically chromosomal binding analysis or bone marrow karyotype, and also we are doing systematic RT-PCR for BCR-ABL1. So at least to guarantee that we don't miss Phi-like leukemia. FISH was at least in 2023 used very occasionally, or detecting using RT-PCR for other transcripts. And we can see from our comparison that anomalies which are detected classically by karyotype are well detected. But the cryptic translocation, which is classic and a very recurrent translocation in pediatric ELL, is missed because it's cryptic to karyotype. And also we are under-detecting KMT2A rearrangement or intrachromosomal amplification 21, as well the new entities as Phi-like leukemia and the other. So now our perspective in this work to set and to address a foundation for advancing our protocol and detect more anomalies basically is oriented to consolidate the classic cytogenetic anomaly detection, but also prospect for new entities or as Phi-like leukemia and the other leukemia, which is complicated, as I said before, because this class of leukemias are a mix and they combine different and heterogeneous genetic alteration. So countries, they are using low density array or qRT-PCR multiplex or different integrated algorithms combining FISH, LDA, RT-PCR, and even NJS to detect the different genetics within these groups. So our first idea is to implement at least or consolidate our protocol by FISH probes for targeting. FISH is a target technique, so we target more classic anomalies, and also with the new entity we can detect few of them by FISH, but also to add MLPA as a cost-effective, simple, and easily validated technique in a lab. Specifically this kit that I report here, which is combining different copy number variation that could be detected, and they have prognostic value, and they can also orient toward new ELL leukemia. This reflection was supported by this publication of a big cohort from UCAL protocol. And we can see that within these new entities, combining FISH and MLPA could at least detect third of genetic alteration, comparing to chromosomal binding analysis, which is detecting very little from these entities, but certainly less efficient than using a target next generation sequencing or even whole genome sequencing. So this is our first reflection, is maybe to consolidate with the basic techniques as MLPA FISH, our protocol, but also to have a view on how we can expand and build our capacities to go toward a target next generation sequencing. And this is just to say that between our multidisciplinary work was based with in discussion on, inside the national group of pediatric ELL, and we are trying to use a scoring criteria like what is the therapeutic impact of these biomarkers or genetic alteration, which is the technical feasibility and also the cost of the technique behind, so we can at least have a view on what we can implement, which is the most impactful and also feasible for a first step to consolidate our protocol. So that was the idea. It's we need also to see the feasibility, which is including the turnaround time. As we know, we all know how next generation sequencing is working. We need to ensure that we can respond in diagnosis with a certain turnaround time, which is usually accepted about 15 to 20 days. So this is our first draft, and we still look forward to discuss it more with the clinician and to decide if that's feasible for at least 4 regions in Tunisia where are located the 7 university centers. So we can really standardize this protocol and ensure that patients in any region or children with leukemia in any region can benefit from the same taken charge, and we have a common at least protocol for the therapeutic, but also from the lab side. So we need to have these systematic tests as initial workup with the diagnosis of leukemia, which is karyotype or chromosomal binding analysis. It's still useful and orienting toward different abnormalities, detecting or orienting to different abnormalities. But and also we need to ensure keeping up in all the centers with the BCR-ABL1 by RT-PCR, as we are doing now and for many years now, because it's very important to not miss any Phi ELL. Because as you know, the target therapy tyrosine kinase inhibitors. And also we need to consolidate our detection of ATV:CSRNX1, and with MLPA we can have a new insight for copy number variation and orientation that maybe a Phi-like is there is a Phi-like leukemia, and we need to be maybe confirmed by FISH analysis. So for a second line, if still not classifying our leukemia with the genetics, as a second line, we have to look to FISH break apart probe KMT2A, because certain translocation or rearrangement of KMT2A are not well detected or overlooked by chromosomal binding analysis. Also FISH for intrachromosomal amplification 21, TCF3, and validation if there is orientation of Phi-like by MLPA. And also we are keeping our effort here to integrate more in target DNA and RNA sequencing with the research project, with capacity building in our laboratories, so we can, in another phase at least, ensure that we can expand our detection and lab protocol for different mutation and different fusion genes that maybe with these target techniques we cannot detect. So just to conclude, collaborative efforts aimed at ensuring access to optimal cancer care for every child with cancer. So it's always interesting to keep on our efforts locally and regionally and internationally to have collaboration and to expand and ensure more access to therapies and also to lab new techniques. Pediatric ELL risk stratification is increasingly requires integrated genetic and molecular testing, and we need to maybe consolidate from our countries the lab work with the first, at least high impacting testing with the minimum protocol. I mean, with at least cost aware and possible methods. And we look to work on also expanding our technique lab with high throughput technique and pangenomic techniques, next generation sequencing. And to finish, I would like to acknowledge and thanks my colleague in the Medical Genetic Laboratory, Dr. Amouri, Dr. Ayed, and Dr. Jalloul, MSc student that I'm directing, and she's working on MLPA result for ELL to consolidate this technique in our laboratories, and also the pediatric ELL group, which is part of the Tunisian Society of Hematology, and ATEL, which is the Association of Leukemic Children Patient in Tunisia. And thank you so much for listening.
Dr. Chaka, we are very appreciative of very excellent presentation. Because of time, I'll just go ahead and ask for just 2 questions and 1 comment so that we can go into next presentations quickly. Thank you for that very
Thank you so much.
insightful.
And I think Dr. Shaima is ready now with her presentation. Well,
Yeah, I
open.
made it. I made it.
Great.
Okay.
Finally.
Okay. Please, but the time is short. You try and see if you can reduce your time, please.
Yeah, don't worry.
All right. Thank you. You can start.
Yeah, I will not long. So, hi everyone, my name is Dr. Shaima Al-Mehdawi, and today I'll be presenting the cytogenetics and molecular abnormalities in ALL, a study that we conducted here in Morocco with my professor, Siham Sharqawi, who's here today with us. So just a brief introduction. As we all know, genetic characterization became very fundamental when it comes to malignant hematologic diseases, especially now in ALL, as we have, as it is the most common pediatric cancer that represents 25% of cancers in children under 15. So today, cytogenetic analyses such as karyotype and FISH remain essential at diagnosis. But molecular techniques, as Dr. Shaker already said, such as PCR-based methods, MLPA, SNP arrays, RNA-seq, and next-generation sequencing now offer complementary and sometimes more sensitive tools to detect clinically relevant abnormalities for us to adapt our treatments in different cases. So just quickly going around Morocco. So in Morocco, ALL represents 12 to 22% of childhood cancers and has a 5-year prevalence, all age combined. Some studies in Morocco have described the cytogenetics and molecular abnormalities of ALL in children and young adults, but few described the importance and impact of genetic research in treatment adherence in this population. So until 2020, the access to cytogenetic and molecular testing was unfortunately limited, highlighting why it is important that our study is. So just a project overview. This project was part of a PhD thesis, and that was it was divided into different parts. But today I'll be presenting mainly the first part, which is characterize the prognostic impact of abnormalities and analyzing our cohort from 2014 to 2024 to actually, I'm sorry, 2018 to 2024 to actually detect the different abnormalities that are in our study. And the second part was mainly a spotlight and a close-up to the ATV6-RNX1, as it was the most common abnormalities that we witnessed in our study. So we decided to do a little close-up that I will be presenting quickly in this presentation. So our study was conducted in the 20 August hospital in Casablanca, more specifically in the hematology and oncology department, the pediatric section. And the data collection methods included both quantitative and qualitative approaches. So for our global cohort, as I said, it was a study between 2018 and 2024. A total of 103 patients were diagnosed with acute lymphoblastic leukemia, and they were included in this study. And the median age was 7 years, with a mean age of 8.5 years. The most common presenting symptoms was anemia, followed by infectious syndromes and hemorrhagic syndrome. Physical examination revealed in several patients a tumoral syndrome in 55% of cases. So as you see, the age between 1 and 10 years old was the most common, representing 61% of our cohort. And we had more male than female representative. And also we had more BALL than TALL diagnosed in our department and our hospital. So our main focus today is more than demographics, but it's more cytogenetics. So among the 86% of patients, who underwent karyotype analysis, normal cytogenetics represented the largest subgroup. We had more than 44% who had normal karyotype, and testing was unsuccessful, unfortunately, in 17 patients. Hyperdiploidy was also detected in 14 patients, of whom 10 also carried the chromosome 21. And the balanced translocations, such as translocation 922, 119, 411 was also diagnosed in several patients. So this distribution reflects the predominance of normal karyotype and hyperdiploidy among the cohort, with the recurrent abnormalities involving chromosome 9, 11, 12, and 21, as well as key leukemia-associated translocations, such as translocation 922. And the fact that we had a lot of normal cytogenetics pushed us to think that we might be missing a lot of abnormalities that we can actually adapt our treatments on. So among the 67 BALL patients, FISH testing was performed in 42 cases. So no FISH analysis was conducted for TALL patients. And the distribution of FISH detected genetic abnormalities revealed lineage-specific and age-related patterns. So as I said at the beginning, we had more ATV6-RNX1 patients who were diagnosed in this cohort. And for the age group correlation with FISH results, we had between the age of 1 and 10 group, we had 6 patients who actually had the ATV6-RNX1 chromosome positive. Same goes to TSF3-PBX1. For the MLL rearrangement, it was between the 1 and 10 and 10 and 15. And for BCL-ABL, we had 5 patients, and they were distributed between different age categories. For relapse, we had relapse rates that varied across different genetic rearrangement detected by FISH. So out of the 5 patients positive for BCL-ABL, we had 2 cases who experienced relapse. Among those with ATV6 RANX1 fusion, we had 3 out of 6, which is 15%. And for the MLL, none of them had relapse in the beginning of our study. Oh, and also notably, 2 of the 3 patients who had a TCF3 and PBX1 fusion have relapsed, marking that this group with the highest observed relapse proportion in these cohorts. So as for the survival rates, the early divergence between overall survival and event-free survival reflects that relapse preceding death, while the curves converge after 5 years, that suggesting that more deaths were relapse-driven, as we can see and notice in our study on different stages of the disease. So this is why one of the reasons we had the focus on the ATV6 RANX1 fusion, because as we know in different studies, the ER is a good prognosis on different cases. But unfortunately, we noticed that we had a lot of patients that relapse. But we also have a specific note that ATV6 RANX1 fusion causes very late relapse. And that's something that we also saw during our study. So from the overall study, we took 19 patients at the end of the day to test. And from that selection, we had patients who were either at the initial diagnosis or at relapse to actually compare both. And we investigated both groups. So we had as we see also in different studies, the most common age group is between 1 and 10. So for the fish finding, the ATV6 RANX1 was detected, as I said, in 6 out of 20 cases, which is 30% of the total number of our patients, with a frequent occurrence of deletion 12, 4 out of 6 were positive, and abnormalities related to chromosome 12. The one patient that was excluded from the study because we had 20 at the beginning and then we took 19 because he left the treatment at the middle, also showed a positive result of ATV6 RANX1 and had a normal karyotype at diagnosis, which pushed us more to think that it is important to actually explore normal karyotype because it might hide a lot of abnormalities that we can treat during the whole way of the patient. So I will not go through different articles who actually have the same results of our study, but what we should know that our study between 2018 and 2024 these results had been reinforced with reported studies on different level when it comes to age, when it comes to immunophenotyping distribution, but also when it comes to the importance of cytogenetics and molecular diagnosis at the beginning of treatments. Our focus on ATV6 RANX1 showed us that we need to care more about the cryptic abnormalities, that we need to have a close eye to the different abnormalities, but also on a normal karyotype level, because it might hide more than we can actually see. So just to conclude, this research has highlighted different critical visions on different abnormalities, and that in the future, we need to include improving genetics diagnostic methods to enhance therapy adherence and explore more targeted therapies that leverage identified genetic alteration, particularly for high-risk subtypes. So there you go. I tried to be quick as I know that the time is ticking. But if you have any question, don't hesitate to
You have
ask.
done absolutely well. Thank you. The speed with which you ran that very insightful slides is appreciated. Thank you. Maybe we should spend about 2-3 minutes to take questions for all presentations. And then you take comment, I'll make comment, then Professor C.K.O. Williams is going to also give us a closing comment before we go. Any question from the audience, please? Okay. Okay, there's a hand there. Please come up. I cannot see the name. Can you please come up with your question? Introduce yourself and let us hear you. Oh, that's Professor Williams. Prof, you are
Sorry,
muted.
yeah.
Okay. Okay.
Yes. Oh, I'm okay. Yeah. Listen, I'm just coming. Wanted to say a few words since I did not hear anybody else saying anything. But I think we've had three very wonderful presentations today, and I would like to congratulate each and everyone who has presented today. This is very, very high class. I'm very happy that this is going on in Africa, especially in North Africa. And we have something to rest on. There's a lot of research ideas coming out from this presentation. So in particular, I enjoyed Professor Hand Shirka's concluding the presentation. I've been thinking about this. It looks to me like ALL in North Africa is very, very much like the ALL as seen in developed countries, in Europe and America. It's very significantly, probably significantly different from what is happening in sub-Saharan Africa. And we don't have enough time to discuss this. I was very happy to hear Dr. Sharkar talk of ETV6 RUNX1 fusion being quite common in some populations in North Africa. She also spoke of cryptic abnormalities. And I'm just wondering what those are. About 4 decades ago, we were able to show that ALL had evidence of environmental influence in Nigeria. And of course, that's a long time ago. I believe that things must have changed between then and now. The point I'm just trying to make is that we know that ALL starts prenatally with the genetic abnormality, such as the ETV6 RUNX translocation. And some of these cryptic abnormalities. The question is whether these abnormalities, which are believed to be universal, are also influenced environmentally. So we cannot discuss that right now. So there's a lot of things going on, but the point is there is a lot of materials for research here. Now the presentation on the Philadelphia chromosome-associated ALL that was made initially by Dr. Abdeni. That is also very interesting. I just came back from a meeting at ASCO. ASCO ended yesterday with a very interesting presentation on the management of BCF, chromosome, what do you call it, Philadelphia chromosome-associated ALL, and the management. They're now recommending that imatinib is not the right TKI to use for the management of this disease, and it should be considering using something like dasatinib or ponatinib, and things like that. The question of a bone marrow transplantation is being reviewed and may not be necessary, as a matter of fact. Anyway, so there's a lot of things going on. Three very beautiful presentations, and we just have to spend some time in sitting down and looking at things and trying to work out our own research programs. So I think very, very encouraging developments, and we can go from there. Thank you.
Thank you very much for this additional insight, Prof. We appreciate the three presenters. I've been wondering personally why or if ETV6 is an actionable mutation, and the FDA had approved 2 molecules that target ETV6 mutation. And there we are with some patients, 6 patients in this last presentation with ETV6 mutation and the wrong fusion that's occurred. With informatics going to it and then applying some of these approved FDA molecules, could it improve the outcome for these patients that express these mutations? These are things that AORTIC, when we take, say, 6 from Morocco and some other countries and see, we now have a situation where if we have the funding, we could see if this molecule, this cohort of patients can benefit from the actionable mutations that go on, like ETV6, which, for instance, like entrectinib, it has been made and approved because, in fact, it had expedited approval for patients that express these mutations. So the question I want to ask to Dr. Chaka and the last presentation to see, did you envisage, apart from identification and characterization of the disease, is there either in the future an attempt to channel this information towards a clinical trial or to look for those actionable mutations and see if these molecules can be used to help this patient?
Thank you.
Yes.
Thank you for your question. Basically, maybe there is not a target therapy for a TVC Ranix 1, to my best knowledge, but it's
Yes.
still very useful for clinical trial because this is how we are stratifying the risk of leukemia. For example, the example of ETV6 Ranix 1 is a good prognosis leukemia, so standard risk, let's say leukemia. But the point, which is interesting, as Dr. Shaima, she said, that we don't know exactly if it's a good prognosis in our population, and also the research advance that additional abnormalities may change the good prognosis of this molecular finding. So maybe the group is heterogeneous, and we didn't see. We need to know more about the molecular landscape of this group of leukemia. I think we noticed maybe the same thing from Tunisia. And we have also, as Dr. Williams said, we don't know, it's cryptic, it's only the technique is not allowing us to see as much as possible fusion TVC Ranix 1 if we are doing only karyotyping. But also, even with molecular technique, we need maybe to keep an eye on our hereditary and foundation of genetics, because that may be also explain fusion genes that are reported with a standard risk, but maybe we can see that in our population, we have a different prognosis, whether because we are not detecting additional abnormalities or because we have also predisposition to leukemia that we need to reveal more with the research endeavor. Thank you.
Say a few more words. I believe that from the work that somebody like Mervyn Graves did several decades ago, acute lymphoblastic leukemia originates from prenatal genetic lesion. The ETV6 runs translocation is probably universal. That is, almost every child is born with this abnormality, but not every child develops acute lymphoblastic leukemia. acute lymphoblastic leukemia develops as a result of other interactions on these pre-leukemic lesions with which almost every child is born. So the ETV6 runs is almost universal. And some people lose it as they go along in development. And so the question is, what happens after birth? A lot of environmental factors, then interact with these lesions, and they will see all kinds of, forms of acute lymphoblastic developing, various, types of life. But the basic abnormality occurs prenatally. And that is something that we can do in Africa to actually look at the different socioeconomic classes and the type of acute lymphoblastic leukemias that they develop. Some of them will probably have these so-called cryptic abnormalities. We probably need to use something like next generation facilities, NGS, sorry, I don't want to take too much time, but this is a very important field of, for research, and hopefully we'll be able to work together to work out some protocols for the work in the field. Okay.
Thank you very much, Professor Williams. Yes. So further discussion on this matter, we can go on to the Aortic Hematology Oncology Research Group on our WhatsApp page. We can continue with this discussion there. Perhaps this guy is going to lead us to formulating research questions that can involve many countries, many West Africa, North Africa, to see if we can collectively put our resources together to answer some of these basal questions. This will be very helpful for bringing out the information. So hopefully, we hope that in the future, we should be able to identify presenters that are presented in another language so that we can get the language tool that interprets so that some people will not be entirely lost. But I'm happy for today, so the slides were in English, so we're not entirely lost. May I seize this opportunity to thank all the presenters who took time to prepare wonderful slides, and they were able to share wonderful insight with regards to ALL, pediatric ALL, with the rest of us here. And with many of us who were able to follow through from beginning to the end, I'm sure we're able to pick something in regards to how this disease works, especially going down further at the genetic level. Thank you very much, dear ladies, for your fine presentation. We look forward to moving to East Africa group to be able to get the next round of our webinar number 3. But before I go, I want to thank the Aortic office in South Africa for the wonderful work they have done for us, not only in getting a very fine flyer for us, but circulating the meeting far and wide so that we would have this number. If the number that are registered were able to attend, it would have been a lot more bigger house than that we are seeing here. So we thank Belmira, who might still be here, for the fine work she's doing, and we look forward to further engagement in the next 3 months that's coming. Thank you very much, everyone, for attending and for still spending time, in spite of the fact that we spent so much time ahead of more than what we had actually anticipated, which is 1 hour, but you still stayed on. We thank you very much. Thank you, everyone, and bye-bye. Take care.